everyone, my name is Tobias Mattei. I'm the deputy editor and host of the NASSJ podcast, and I have the pleasure of having with me here today Dr. Minjin Fromm, who's from the Department of Orthopedics and Physical Rehabilitation at UMass Chan Medical School, and she's the first author of a systematic review recently published in NASSJ entitled Factors Associated with Improved Outcomes After Lumbar Transforaminal Epidural Steroid Injections for Radicular Pain, a systematic review. Thank you very much for your time, Dr. Fromm.
Thank you for having me.
Perfect. So this is a very well done systematic review of the literature, but would you provide us kind of what were the gaps in the literatures that you saw and that you tried to address with this study?
Yeah, so I'm an interventional physiatrist, and we have a lot of patients come in for, lumbar radicular pain who are seeking, some pain management options beyond the, usual care of physical therapy and medications. And, even though the epidural steroid injections have been performed and described since the 1950s, there's still a lot of controversy regarding their efficacy. And even in my own practice, I see patients with variable treatment responses. And I wanted to be able to identify the factors that could explain why some people respond very well and why some people don't. I believe that there's a subgroup of patients who do well and some people who may not respond. And I wanted to look at the literature to see what prognostic studies had been done to help me in my own clinical practice to guide patients better, but also help patients with informed consent, because many patients really, they look me in the eye and say, hey, you're recommending this injection. Do you think it's going to work for me? And, I wanted to be able to give a more tailored and individualized answer for patients because they have different pathology, they have different characteristics. And the more that I could understand, what factors were associated with, a successful response, the more I could help them and, better understand what I do. And in effect, maybe it could inform future studies so that instead of just, doing injections on, I think it could inform future studies that they could separate different characteristics and assess like the treatment response. Because if you pull everybody together and we know that some people are not going to get better because of some pathology they have, then it kind of muddies up the data. And I think that's probably why there is such a mixed studies on this topic.
That's a very insightful, because I can tell you as a surgeons, we always try to pursue conservative treatment, and injections, be it transforaminal or caudal epidurals or even facet blocks, rhizotomies, we always try those strategies before going for surgical intervention, unless a patient has an acute neurological deficit or something like that. But regarding the efficacy, I mean, some patients always complain, oh, I have someone in the family didn't do well with injections, or I didn't do well in the past. So it seems almost like a 50-50, but I agree that, I mean, I have my personal experience that I think some cases are not good for injections. So for instance, extruded fragments in large disc herniations, I usually tell the patients whatever benefit you may get with the anti-inflammatory effect of the steroids, you may lose because you're injecting 5 or 10 cc's of something in a place where there's already no room. So it may be very problematic in that, but it's good to have that. I mean, I don't want to base that decision making just on my personal experience. It's good to have the data, especially if you're pulling from several studies. So walk us through the methodology of your study, how many papers you initially identify, your exclusion criteria, and what was the final sample you based your final analysis on?
Yeah, so I based the inclusion and exclusion criteria on kind of patients that I see in my own practice. So I did include patients who had spinal stenosis as well as disc herniations. I excluded patients who had prior surgery and cancer or infectious causes of radicular pain. I excluded patients who had only axial back pain because I don't recommend this procedure for that. I also wanted to make sure that I studied really one injection, like the transforaminal approach, rather than mixing the study with all different epidural approaches. So there's the interlaminar, the caudal, and the transforaminal, because there are different procedures. There are different places in the epidural space where you're injecting the medication. You know, the transforaminal approach goes into the anterior epidural space, and the outcomes are different. So I wanted to narrow it down to that. I also wanted to only look at articles that did updated techniques, because I believe the technique is also important when performing the procedure. So using imaging guidance and contrast medium. And then I also restricted articles that kind of that limited, so that the success had to be greater than 50% pain relief, which is, you know, clinically relevant. So the methodology was to try to ask a relevant and yet simple question on a, you know, a specific procedure, so that when whatever answer I came up with, it could be applicable and clinically relevant. So we came up with 18 articles, 9 were prospective and 9 were retrospective studies. And most articles didn't just look at one prognostic factor. Oh, and these are prognostic studies. Most articles actually looked at multiple prognostic studies, and we looked at all the secondary prognostic factors in the data analysis. There were about 20 different prognostic factors that these articles looked at. I divided them up into 5 broad categories. For example, like the patient characteristics, their either age, their BMI, their symptoms, the pain intensity, the pain duration, then the physical exam findings, imaging findings, EMG findings, and any anatomical variations, like if they had a transitional vertebrae, or in one article, they studied facet tropism, which was, to me, very interesting, because that's not something that it's commonly looked at when, you know, thinking about whether someone's going to respond to an injection, whether a variance of 10 degrees or more at the same level has a relevance in terms of an outcome. So yeah, so I can tell you the findings. The overall is that most studies looked at imaging, or specifically MRI characteristics that would predict outcomes. And we found that the lower grade of nerve compression was associated with better outcomes. The location of the disc herniation, if it was a disc herniation, was relevant too, in that there were successes with central herniations, foraminal and extraforaminal, but if it was in like the subarticular location, it didn't tend to have good results. We also found that if a disc herniation also was accompanied by degenerative changes like stenosis, it really did not have any association with outcomes. And in my study, if it was a disc herniation versus spinal stenosis, there was also no really association with outcomes.
And I think that's very compatible with our clinical practice. What I see is exactly what you're saying. I mean, epidural steroid injections are very good for those patients with some degree of disc bulging, be it central or foraminal, extraforaminal, but paracentral disc herniations, those in the lateral recess, especially if they reach a meaningful size, those are the patients that, even though they may go to ESIs, I think they ended up progressing with the need of surgery. So sometimes I even at least offer them the option of surgery up front. And as you mentioned, I mean, EMG without significant abnormalities, I think that makes sense, because, I mean, if you have already signs of severe denervation or something that the nerve, even though you may not have a motor deficit, I think that may be a good indication to consider surgery instead of a more conservative approach. Any other findings in terms of the demographics of the population, or in terms of age or smoking, diabetes, anything like that was consistent throughout the studies?
So really the demographics that you might think anecdotally might have a relevance, we really didn't find, like age, BMI, smoking status, workman's comp status. There weren't a large number of studies among the ones that I selected that had a large number of patients that studied, let's say, workman's comp status, but the ones that I found did not show an association. There was definitely some mixed results in a lot of areas. So I think that means that, it's still up for debate. Perhaps there need to be more studies on that topic, but for example, pain intensity, there were some studies that where more pain, like higher pain intensity was associated with positive outcomes, but I didn't put that in my results because it wasn't corroborated. There were single studies and there was a lot of it was mixed, so that I couldn't really make any conclusions about that. So really no clear association as of yet.
And I think that highlights the importance of involving the patients into the decision making, right? Especially when we don't have strong evidence pointing towards factors that may be very strongly predictive of a response. I'm very honest with my patient. I can tell them based on my experience and the literature what I think would be the best approach, but I think it's important to keep an open door to the alternatives, be it just physical therapy, injections, or even surgical intervention, and let the patient kind of decide how aggressive they want to be in terms of their treatment based on their past experience or their approach to injections. I know some patients had that in the past and they're very happy with the outcomes. Some patient had what they report worsening of pain throughout the injection, and they definitely don't want that, but they still are willing to try some other form of conservative treatment. So I think that's very informative to our clinical approach on the issues. And I know one of the things I want to discuss with you, and I think your article is very timely. There's been a big controversy regarding that editorial published at the British Medical Journal, and basically, and there was even a response from NASSJ and multiple other pain organizations with strong criticisms on the methodology. And basically, that it was a large study, it was a similar approach. In terms of trying to gather the data on the literature on the efficacy of interventional pain procedures, but I think they went exactly the opposite way you did. I mean, you selected, even among epidural steroid injections, you decided to study only transforaminal, and you tried to have a very homogeneous, at least intervention from the technical standpoint. And that article, which surprisingly ended up with a very aggressive conclusion that there's moderate evidence that pain interventional procedures for back pain and radicular pain are no different than sham procedures, which is something that it's not a light conclusion that you can take, especially because it kind of, I mean, this is the mainstay of conservative treatment for most spinal pathologists. But one of the criticisms, and we see that in the NASS response letter, is that, I mean, they evaluate radiofrequency ablation, which is something that is not even approved by insurance in the US. And at the same time, epidural steroid injections, facet blocks, rhizotomy, cervical spine, thoracic spine, lumbar spine, SI joint pain. And when you mix apples and oranges like that, to the point that it's not a homogeneous group at all, it becomes very challenging to have any meaningful conclusions regarding the efficacy of every procedure in question. So I would like your comments on that, and I'm sure you're aware about that paper and the possible repercussions, even in terms of guidelines by societies and insurance approval, probably more in Europe than in the US. But feel free to compare your results with their results and your whole take on the matter.
Yeah, like you said, we took a different approach. They kind of combined cervical, lumbar, epidurals, and all the 3 different epidural approaches into sort of one category. So that is, to me, that kind of muddies up what you're studying, because really I don't think you can really compare to group those in one category. I also noticed, it was the type of procedure that they described as like joint pulse radiofrequency ablation that you're referring to, and it's something that is not commonly practiced here, or I don't believe is even approved. So that they included that. I also noticed that they didn't necessarily, so like I was saying, the technique is important. I don't believe that the articles included only, imaging guidance with contrast medium. I noticed that many of the articles that they looked at didn't even necessarily have imaging as a requirement for inclusion in the study. When they looked at the radiofrequency ablation, you have to do the medial branch blocks before to have a diagnostic block. And many of the articles that they looked at didn't have any specific criteria of success for diagnostic block. Usually you want to use higher, say 80% relief is the strictest criteria of relief from a medial branch block before you go to radiofrequency ablation. And the studies that they looked at, some were 50 or higher, but some had no criteria reported. So then how are we going to know if they selected the right patients for the radiofrequency ablation? Perhaps they were not going to be responders anyway, that we would have excluded if we used standard practice. So there were quite a bit of issues with that study. And I think the problem is that because they make a blanket, it changed, they put out a guideline after that chronic pain, that the interventions have, no, have low, evidence of efficacy in chronic pain. So that kind of, it's almost like it's like with one, wave of the hand, it really gives all these interventions, makes it sound as if they don't work at all, which again, like what I was trying to do with my articles to try to find that subgroup of patients that do respond. But if you group everybody together and you don't really go by the updated guidelines and how we, at least how we practice, then I don't think those conclusions are actually valid. And the worry is what is going to be done with that information, how people are going to interpret that, and what changes might be made to patients who really need options. And, if you don't try injections, injections, of course, are not for everybody. They don't help everybody with every problem, but they are an option that, then the other options are surgical or, medications, and we're trying to avoid, pain medicine. So what do people have left? So it can be harmful when you have a study like that didn't include, I believe, didn't include any interventional, pain or interventionists in the study, because it's about, the question is important, how you ask the question, the methodology, because we ultimately want to help patients and help our clinical practice. But if you don't have somebody who has an understanding of maybe the clinical practice, then I think the study is not, I guess it's not as helpful, and in some cases can be harmful.
It's at least surprising that a study that has the potential to completely eliminate, at least if adopted by insurance companies, the whole field of interventional pain management, had no one in that specialty, from that specialty involved in the study. And I agree with you that, I mean, it's a basic principle of scientific methodology and soundness of our strategies is to ask very precise questions and try to gather a relatively homogeneous group that we can properly analyze. And I think their methodology of asking about the efficacy of pain interventions, it's almost like trying to do a meta-analysis on the question of whether surgery is effective for spinal problems. I mean, what are you talking about? I don't know what surgery, what spinal problems, I mean, in what population. So when you come with such type of broad questions, it's almost impossible to have an intelligent conversation based on data, especially if you try to use statistical methods to pull together data from studies that are so different and analyze procedures that have completely nothing to do one with the other. So I do share your concerns regarding that, and I think that has been the position of most, not only spine societies, but several national and international pain management societies. Anything else you would like to highlight to our listeners? I do encourage everyone to read the original paper. I just want to congratulate you on the kind of Herculean efforts, not only from the data you extracted and summarized, but you present a very good several tables with some kind of snippets of the vast majority of studies. So even for those who like to have access to the raw data, I think you do a very good job in terms of providing that and with a detailed exposition of what variables were included in each study. So this is a type of thing that the readers don't need to necessarily rely on your summary and conclusions. I mean, they have the raw data there, and if anyone is interested in redoing the study or has a different approach or thinks it should have been done differently, I think it's very hard to criticize at least your selection criteria and what you use. So the data is there in the literature, and those are definitely the largest studies in this field. But again, anything else you would like to highlight to our listeners?
Well, thank you about the tables. I realized that they had a lot of information in them, but like you said, it can be a reference for other people, and it can. I wanted the study to be, reproducible and to see where I was getting my information from. But I think there, the field of pain management is relatively young compared to other fields of medicine, and I think that I think there needs to be more research on, more randomized controlled trials, but also more of an understanding of, like I said, the subset of patients that respond to all the different procedures we do. Because, of course, I'm biased, but I do believe that there is a role for all of the things that we do in the right group of people. And if we can have more data and more, scientific evidence to justify or help even guide us on who benefits from what procedure, I think that will not only I think it'll more validate officially what we're doing, what we're trying to do is, and also not treat everybody the same, have a more individualized approach of like what, let's say, what type of procedure, what route of administration helps a certain type of pathology. And I think overall it would be, so I think more research needs to be done. But I think there's promise. We do know that these procedures do help many people. We just need to understand why and who they benefit.
I agree with you. And thank you very much for your time. And again, congratulations on your publications. And I do believe that this is a very good reference for those interested in the topic of interventional pain procedures, and especially epidural steroid injections for radicular pain, which it's not only a topic relevant to neurosurgeons, orthopedic surgeons, physiatrists, but so I do believe has a very general applicability, and we look forward to have more contributions from your team to our journal.
Okay, thank you very much.
Bye-bye.
Bye.